In this lecture, I will discuss how to do gait analysis of a patient, especially a neuro patient. So there are two types to analyze the gait. One is the general gait analysis and the other is a specific gait analysis. So first we do is general gait analysis. So how you examine is we look for the step length, velocity, the stride length, cadence, foot involvement, and alternate trunk movement. Next is a specific gait analysis. What you examine in this is that heel strike, flat foot, mid stance, initial and terminal swing, phase, and heel up and toe up. So in specific gait examination, we check which type of gait is it and we look for every movement at each joint. It is important to make a video of a new patient when they walk so that calculations can be made for the velocity, step length and a stride length. So in specific gait analysis, you look for whether the gait is normal or whether it is pathological gait. Next is the abnormal gaits. So there are different types of abnormal gaits. Some of them are, first one is the Untitled gait. So Untitled gait is also known as the painful gait. So what happened in the Untitled gait is that patient adopts some type of limping gait, like patient compensate the pain. Like for example, if patient has the right side pain, so patient will avoid the weight bearing on that side. Patient will compensate the gait. This is the intelligent gait, which is the painful gait. Next is the rattling gait. There is a difference between the rattling gait and the lurching gait. In rattling gait, there is a bilateral gluteus medius weakness, but on the other hand, lurching gait, there is a unilateral gluteus medius weakness. So what happens in the rattling gait when the patients walk in a rattling gait? So he performs some kind of circumduction on the leg. If it is a lurching gait, so patient will perform circumduction on a unilateral leg because there is a unilateral weakness of a gluteus medius. But in the rattling gait, there is a bilateral weakness of a gluteus medius. Next is the gluteus maximus gait. So there will be a weakness of the gluteus maximus. So what happened in this is that the trunk is shifted posteriorly and the pelvis moves forward. So while walking, the patient tilts backward and limbs move forward. Like limbs move forward from the center of gravity and your trunk moves backward. So this happens all because of the weakness of the gluteus maximus. There is another type of gait missing here, that was a steppage gait. What happens in a steppage gait that there is a weakness of a hamstring muscle. So when the hamstring muscle is short, a person take small steps which are spastic type. Next is a Tenderberg gait, which is also known as a Tenderberg sign. What happened in this that there is an abductor weakness. Abductor is a gluteus medius and a gluteus minimus. So when gluteus medius and a minimus are weak, Tendenberg gait occur. Like for example, there is a weakness on the right side. The right gluteus medius and the minimus are weak. So what happens on the right side? The hip will move up. Hip hike will occur, and while on the opposite side, hip will drop. Plus, the trunk also moves to that side, and scoliosis will also develop in these cases. Like if patient has a tender buck sign, so involved side will hike up, opposite side will drop, and on the opposite side, trunk shift will also occur, and as well as scoliosis will also develop there. So there are the abnormal gaits which you check generally in a neuro patient. Next is a gait analysis. When you do a gait analysis, there are other things to check like a pes planus, pes cavus, anteversion, retroversion, knock knees, bow legs. You all check each and every point. Whether a patient do weight bearing on a medial side on a lateral side. Like normally, weight bearing occurs on a lateral side, but if someone has a flat foot, so a weight bearing will occur on a medial side. What happens as a result? The medial arch decreases. So normally, when the heel strike occur, weight bearing occur on a lateral side, but if someone has a flat foot, known as a pes planus, so weight bearing will occur on a medial side. So what happened? If someone has a pes planus, it means they have a flat foot. What happened next? That there will be a anteversion. In pes planus case, the anteversion increases. When anteversion increases, what happens next? That on the knees, genovalgum, which is known as a knock knees, develop, and on the hip, coxa vara develop. So when the anteversion increases, coxa vara occurs on the hip, plus the knock knees, that is a genovalgum, develops on the knees. Next is the femoral condyles move internally and the tibial move externally. So when there's a flat foot, arches decreases, toe in gait develops, and the weight bearing on a medial side increases. So all these dysfunction may occur because of a muscular coordination or anatomical issues. Sometimes anatomical structure is correct, but due to muscle malalignment, which contribute to these factors can occur. Next one is the gait analysis, in which we check for the anterior pelvic tail and a posterior pelvic tail. When sternum is in line with the pubis, it means that there is neither an anterior nor a posterior pelvic tail. It's normal. Sternum is in line with a pubis. But when the pubis moves backward from a sternum, it means that there is an interior pelvic tilting. What happens in the interior pelvic tilting? The pubis moves backward from the sternum is that the pelvis moves rotates interiorly and the pubis moves backward and the extensors becomes weak due to the weakness of a gluteus maximus and the flexors becomes tight, and what happens next is the lordosis increases. And next is a posterior pelvic tilting. The pelvis moves posteriorly. Then the pubis moves interiorly, and how you measure is when the pubis move forward from the sternum, it means that there is a posterior pelvic tilting, and this extensive tightness occurs, which is opposite to the interior pelvic tendon, which resides from the pull posteriorly of the pelvis. And what happens next is the lordosis decreases, lumbosacral angle decreases, and there is a flattening of a spine. So both are opposite. In interior pelvic tilting, your pubis moves backward, but in a posterior pelvic tilting, the pubis moves anteriorly and the pelvis moves posteriorly and the extensors become tight. There is a decrease in the lumbar lordosis, there is a decrease in the lumbosacral angle, and in posterior pelvic tilting, there's also a flattening of a spine as well.